Hi, Laura. How are you?
Sorry, I was on mute. Hi,
Yeah, no
everyone. How
worries.
are you?
Hi, Laura.
Hello.
Hi, Carol. How are you? So, hi, Lisa.
Good morning.
Hi, Lisa.
Hi, Rosanna.
Hello.
Good morning.
Good to see everybody
morning.
joining. And we'll give folks 30 more seconds to join.
This is Rick. How many folks did you anticipate joining today?
On average, we've been having about, I want to say maybe, is it 10 to 12 attendees? Noelle, about like 8 to 12.
Yeah.
And then folks definitely join as the presentation is ongoing. But I know this one's a hot topic, so I do anticipate we will have some more folks joining on as we move on.
Yeah, there were 17 pre-registrations for this one
17.
this morning. So yeah, probably a little bit higher attendee rate for this one.
Did you want me to wait just a couple more moments, Rick, for other folks to join?
Yeah, that's fine with me.
Okay, I'll give
Maybe
folks
give it
maybe till about 11:05. I'm sorry, 1:05.
105. Yeah, that sounds good. Thank you.
Laura, thank you for the recorded sessions as well.
Oh yeah, absolutely. I'm glad that you guys are able to utilize those. So yeah, actually, I'll take this moment to just reiterate to everybody that if you guys are interested in seeing past presentations that you were not able to attend, we do have those recorded sessions as well as the slides available on our NCUE website. And I'll go ahead and again post that link in the chat box right now so that everybody has access to that. And then actually, while I have you, while we're waiting for folks to join, if you could please place your name, your organization, your role, whether it's a board of directors role or maybe your role with the organization themselves, that'd be great. And then years on the board. And I will add that right now. Okay. All right. Okay, so I do see some additional folks had joined us here. Okay, perfect. All right. Well, then we can go ahead and get started with the presentation. If we could move to the next slide, please. So thank you all so very much for joining us today. This is the 5th session of our Creating Resilient Board of Directors Members in the Era of COVID-19 series. So again, this is intended for our urban Indian organizations, for their Board of Directors members, and just ensuring that we have the tools needed to effectively create a Board of Directors unit. So I will be today's host. My name is Zipporah Fuller. I am the Director of Technical Assistance here at NCUE. So I'll be monitoring the chat box and just helping to direct any questions you all might have as the presentation progresses. Next slide, please. So just some quick housekeeping items. This webinar is being recorded. All mics have been muted unless otherwise directed. We also do ask if you could turn your camera on to allow for fun interaction, just to help create that same environment that we would if this were a conference. And this will be about maybe a 45-minute to 1 hour session. So just a heads up on that as well. We don't anticipate this being the full 2 hours. Attendee participation right now, we are not going to be using any polling in breakout rooms. So just again, a quick note on that. All of your questions can be typed into the chat box. And again, as mentioned, I will go ahead and relay that to the presenters. A Q&A session will also be offered at the end of this session. So if maybe you have a question that you want to ask at a later time, please feel free to jot that down in the chat box and we can get back to that at the end of the program as well. All the slides and recordings will be available at the link that I have placed into the chat box as well. So you guys do have access to that. And then we also will have an evaluation to follow at the end of this session, as we do welcome your feedback. Next slide, please. So how to ask a comment or question, you want to go ahead and just hover your mouse at the lower bottom of your Zoom screen. There should be a dashboard that pops up. There will be an option to bring up the chat feature, and you can go ahead and type in your comments there. Next slide, please. As mentioned, today's session is webinar number 5 in our series, and today we are going to be focusing on IHS tools for urban programs. Next slide, please. So we have 2 guest speakers joining us today. The first is Mr. Rick Mueller. He is an enrolled member of the Central Council of the Tlingit and Haida Indian Tribes of Alaska and is the Health System Specialist for the IHS Office of Urban Indian Health Programs in Rockville, Maryland. Mr. Mueller holds a Bachelor of Science degree in Health Education and Promotion from Northern Arizona University in Flagstaff, Arizona, and later earned a master's degree in business administration with a concentration in full service administration from Alaska Pacific University in Anchorage, Alaska. Next slide, please. In addition to Mr. Mueller, we also do have Shannon Beyale joining us. Commander Shannon Beyale is currently stationed at the Indian Health Service within the Office of Urban Indian Health Programs in Rockville, Maryland as a health system specialist. Commander Beyale received her undergraduate degree from Northern Arizona University in microbiology and graduate degree from the University of Arizona in public health. Commander Beyale began her career with the USPHS Commission Corps at the Phoenix Indian Medical Center in Phoenix, Arizona as a program planner. To pursue her personal interest in health promotion and disease prevention, Commander Beyale also served as the Health Promotion Disease Prevention Coordinator and Health Education Consultant for Phoenix Area IHS. Commander Beyale is a member of the Navajo Nation and remains an advocate of increasing physical activity in American Indian and Alaska Native communities. If you guys could please join me in welcoming both Commander Beyale and Mr. Mueller. They will go ahead and take the floor.
Hi, just a mic check here. Can you hear me?
Yes, we can.
Okay. Good afternoon, everyone. As you've heard our intros, my name is Shannon Beyale, and I am a member of the Office of Urban Indian Health Programs. And so just to give you a little insight, this Chief Executive Officer orientation, Executive Director orientation is what we primarily provide to new staff that come on board. And what we noticed is earlier on within the last 2 or 3 years is that we've had a lot of staff come on and they have questions as far as like what type of services they want to know about urbans in general. And this is also not necessarily leadership within the urban Indian organizations, but it's also among their staff as well. So this kind of gives you an overall picture of the program in addition to the services that we do provide. Next slide, please. Next slide. So we are a relatively small staff. Dr. Rose Biyaki was appointed as the permanent director earlier last month, and she is also a member of the Navajo Nation. As you look on this slide, there's a number of area offices listed under her name. As far as our office concerned, considering the size, we are each assigned an area in which we provide either technical assistance or answer any questions regarding any type of issues within those given areas. And Dr. Yaki is responsible for the Bemidji area, the Navajo area, Phoenix area, and Portland area. And there we provide also her contact information as well. Next slide, please. And currently, I am the acting deputy director and also responsible for a number of areas as well. Albuquerque area, Billings area, Oklahoma City, Nashville, and Tucson. Next slide, please. And also Rick Mueller, who is also co-leading this presentation with me as well, and he's responsible for California area and Great Plains. And just to clarify, there are a number of more programs in California, so that's the reason why he only has 2 areas. So next slide. As far as Tayrien, she's also our support staff in our office, and she provides a lot of, she takes questions, she takes phone calls, and she does a lot of the moves of things along as far as operations are concerned. And also as far as staff is concerned, to clarify, is that my role right now as acting deputy director does end actually tomorrow, and Rick Mueller will resume the role as acting deputy director from here on for the next 6 months. Next slide, please. And also we have Christy, Tayrien, who is also from the Office of Information Technology, who works closely with Mr. Mueller to provide a lot of that technical expertise in IT. So she's been our arm as far as helping with the UDS data management, in addition to another component regarding evaluation with the data as well. Next slide, please. And we also have a pathway students, and I believe a lot of our programs did receive messages from Haley as we try to engage her in a lot of the communication with our programs. She's also currently a student over at the University of Maryland, and we haven't seen her in a while. She's been quite busy, but I believe that we plan to have her back full time when winter break does come. But she's been an asset for us. She's been doing a lot of work for us in our program. So as far as a list of area urban coordinators, as we discussed earlier, that we do have 11 areas as far as staff, as far as areas in which we have programs. And so here it just is a list of the area urban coordinators in which reside in each of those areas. And they are our point of contact for urban Indian health programs, in addition to other related questions when it comes to urban services and activities. Next slide. Its background and location, as we've mentioned earlier, we are located in Rockville, Maryland. And also to give you some insight is that the program in itself was established in 1976 to provide health care services to make them more accessible to American Indian Alaska Natives residing in urban areas. And so right now we are currently in partnership with 41 programs nationally. And also, as I mentioned, is that it covers 11 area offices across 22 states. And one of the primary roles that we have at headquarters is to provide leadership and guidance as far as providing central oversight to services under the Indian Healthcare Improvement Act. And also one of the other components that we have is working closely with contracts and grants in which UIOs are eligible to provide healthcare services for urban Indians. And most of you are probably familiar with this, being board members as well, is that just gives you a snapshot of the criteria. 501(c) nonprofit organizations defined by their scope of work and services, looking closely at unmet needs within urban Indian communities, and also having a governing board that's made up of 51% urban Indians. And also one of the larger components that we're also looking at is that most programs do provide culturally appropriate and quality healthcare services as well. And that's an integration into a lot of the alcohol and behavioral health services. And also UAOs are an important part of the urban Indian community, as you know, they've made those connections as a close knit as far as having that outlets to meet others who reside in that center. Next slide, please. So this gives you a snapshot of the number of programs we have nationwide. So this outlays a lot of the main sites. I know that some sites have multiple locations, and those sites are not included on this map. So this is only the main site. So there are 41 sites across. As I mentioned earlier, most of the programs do reside more on the west side of the country. Next slide, please. So as I mentioned about healthcare services, so in calendar year 2018, urban Indian organizations did provide 731,349 healthcare services for 17,243 urban Indians. And so this is a collection of data from UDS, and Mr. Mueller will provide more information regarding those efforts. And also, one of the things that has been stated in prior, I mean, even in 1976, when the office in itself was implemented, is that urban Indians don't necessarily have a lot of resources available to them within an urban area, just because, you know, there's tribal facilities, but they are not near, or urban Indians are not near a reservation to access services or direct IHS services to receive health care. And as some of you are familiar, as far as program size and services, we do have 4 components. There's the full ambulatory care, we have the limited ambulatory care, the outreach and referral, and also the residential and outpatient substance abuse treatment programs. Next slide, please. And more specifically, there is a criteria as far as identifying the various programs. For full ambulatory, there are 40 or more hours of direct medical care that is provided. For limited ambulatory care, it is less than 40 hours per week. And also, a lot of the outreach and referral programs do provide a lot of case management, in addition to a lot of preventive services around health promotion, disease prevention, or just prevention services in general. And we also have a number of residential treatment centers that provide more in-house, in addition to outpatient substance abuse services. Next slide. And this is just a snapshot of how the services are broken out as far as being provided from UIOs. There's the components are primary care, general medical care being received. That includes a lot of wellness checkups. There's the behavioral health component, which is really blended together a lot with medical health services and substance abuse services. And a number of other services. From what we've recognized is that, you know, each of the UIOs do tailor a lot of the services to the environment in which they are, and so it really depends on how they are implemented to serve services within that area. And we also have nutritional healing and medicine. So some have the sweat lodges or other type of ceremonial services they provide, and in addition to that, you know, the social and community services that a lot of programs provide to bring the family together. A lot of youth camps and programs are provided, and also elderly services. Next slide, please. And I believe I'm handing this over to Mr. Mueller. Rick?
Yep, hello, sound check, can everyone hear me?
Yes.
Yep, hear you.
All right, great. Well, again, good to be here. My name is Rick Mueller, Health System Specialist within the Office of Urban Indian Health Programs. I've been with the office now for going on about 7 years, and prior to this, worked primarily in the state of Alaska for various health corporations. So it's really good to be here. I'm just kind of looking in the group chat, and I see folks, board members from Bakersfield, Santa Clara, and Phoenix, and Salt Lake. So again, glad you're here, and hopefully we can provide some good information for you all. This slide basically shows the number of American Indian Alaska Native patients that the 41 urban programs see in a given year. This is for calendar year 2019. This is something that we share with NCUI on a yearly basis, and they usually share this information at the annual budget formulation meeting, just to show other tribe members that are there, who's being seen at the urban programs, and to definitely make urbans a priority as far as budgets go. So this is the top 10 here. Usually holds true every year, but you can see that the Cherokee Nation is by and far the number one tribe that's seen at the sites, and that stands to reason as two of our biggest urban Indian organizations are both located in Tulsa and Oklahoma City. Next slide, please. Okay, so there are some differences as far as who's eligible to be seen at an urban Indian organization. And so we've kind of put together this table that shows a side-by-side comparison of who might be eligible at an IHS facility versus an urban facility. And let me see if I can, yeah, okay. So I put in the chat box where the statute can be found. So feel free to cut and paste that and do a little bit more in-depth research on your own on this. But primarily, you can see where urban Indians and IHS facilities both see members of federally recognized tribes, member of terminated tribe or band eligible at urbans but not IHS, member of state recognized tribe are eligible at urban programs, not eligible at IHS facilities. Descendant in the first or second degree, yes for urbans, no at IHS. Non-Indian women pregnant with eligible Indian children, not eligible at urban programs, and are eligible at IHS facilities. Non-Indian members of an eligible Indian's household, no for urbans, yes for IHS. And then California Indians, yes for both. And again, I've put in the chat box the statute where you can find that and get more information. Next slide, please. Okay. So this is the percent of urban Indian organizations by type, and like Shannon said, we have 41 urban programs throughout the country, and it should be mentioned that there's at least one urban Indian organization in each of the areas except Alaska. Alaska is the only IHS area where there is not an urban program located. So you can see here from this that the majority of the programs are full ambulatory. And then second, we have 15% outpatient and residential alcohol and substance abuse treatment centers. And then at 14%, we have limited ambulatory, and then 15% we have outreach and referral. And I just want to mention that this could change. You could have a program that goes from outreach and referral to limited ambulatory, or limited ambulatory to full ambulatory. In the 7 years I've been here, I haven't seen that happen, but we do get questions occasionally. There is not a formal process to go through that. This is just a way to kind of categorize the different programs by types. And I don't think it's in the slide presentation, but basically a full ambulatory is defined as programs for providing direct medical care to the population served for 40 or more hours per week. And then a limited ambulatory care is defined as programs providing direct medical care to the population served for less than 40 hours per week. And then outreach and referral programs providing case management, behavioral health, counseling and education services, health promotion, disease prevention education, and immunization counseling, but not direct medical care services. And then finally, residential outpatient substance abuse treatment programs providing residential and outpatient services, substance abuse treatment, recovery, and prevention services. And also that particular category, the outpatient and residential, just recently in the past couple of years, we did take on some more programs. They were known as former NIAAA programs. And so that took our number up to 41. And so they're relatively new as far as being categorized as a urban Indian organization. So that's just for your knowledge. Next slide, please. Okay, and then here I'm going to hand it back over to Shannon.
Thank you, Rick. And so on the slide here, just gives you a snapshot as far as the Office of Urban Indian Health budget. So in fiscal year 2020, the Urban Indian budget line did receive over $57 million. And it's listed there, just gives you a number of activities that, our office does to improve the health of urban Indians. And I think one to point out as well that also we work with NCUI with is to enhance the Urban Indian Organization third-party revenue. We have been addressing that through the cooperative agreements. We also been increasing the number of accredited organizations, and I believe that we did add one this year through Native Health, who had their Mesa location accredited in October. So there's a number of initiatives that we're working toward to increase services, to ensure that quality health services are being provided to urban Indians, and how we are also implementing the Indian Healthcare Improvement Acts specific to UIOs. Next slide, please. So as far as the Urban Indian Health Program in general, just gives you a snapshot of the various statutes that apply to our program. These can, as Rick mentioned as well, this information can be found on the web as far as looking specifically at law, looking specifically on how it applies to our program. So as you read at the bottom there, it says in the policy of the IHS to what we've mentioned in prior is to provide services to urban Indians, support community programs, ensure that eligible patients and clients, regardless of age and sex, in addition to evaluate and monitor program performance of the programs that are IHS funded as well. Next slide. And one of the larger policies that we do implement, and we do this also in unison with NCUI, is the Urban Confer policy. And so this can be found at this location, and it also can be found on the IHS.gov website. If you're wanting to see the specifics of this policy, you can go to the site and type in the Urban Confer policy in the search box, and it will bring up the various choices that you can look at. So one of the things, the reason why is that we decided to implement this policy in prior years is to ensure that the urban Indian programs had a voice. As you see there, it's what's defined as a confer. It is an open and free exchange of information, making sure that there's an understanding between the two parties to hear each other as far as if there's any outstanding issues that need clarification. And also it's looking at the critical issues, something that's affecting one or more UIOs, where you need to come to the Indian Health Services to discuss that complex issue in a time where you can exercise this policy. Lately, and typically in the past, before the pandemic, most times the confers were in person. But now the Confers that have been taking place are happening virtually as well. Next slide, please. As I mentioned earlier, the accreditation effort is one of the things that our office looks at closely. As far as I know that a lot of programs have reached out to us to access this contract that we currently have in place. So we did renew it for fiscal year 2021 in the amount of $50,000. And so the services that are provided cover an array of things. It can cover accreditation of a new organization. It also covers attending a seminar. So if any of you board members are interested in attending a seminar, please let your chief executive officer know that you'd like to have a better understanding of what this is. And so then we can definitely work in getting you signed up. And right now, AAAC is offering a virtual session that's scheduled for December. I do plan out to send out correspondences soon. It's just that I'm still waiting to receive information back from AAAC just to confirm that indeed it is happening. But and then I will provide that information. So in fiscal year 2021, yeah, we'll stay on this slide. And this gives you a little bit of specifics as well, that we did provide services to 24 programs. And a lot of those programs did attend seminars. And one of the things that's moving from the effort, that a lot of them now are seeking to move on to the next step, which is to start looking at their organization more closely to see if they can get ready for survey. So we did create a guide from this effort that provides a list of services. There's mock survey, there's the accreditation that takes place, there's seminars. You can have access to prior webinars that were recorded in the last 3 or 4 years, just to see what was covered, or if you're interested in any of the topics that are available. In addition to resources, I know that in the past we've sent out what they call patient toolkits to a number of our programs that provides information regarding primary care. Next slide, please. And I'll hand it back over to Rick.
Thanks, thanks, Shannon. So the next topic is the uniform data system. And again, I'm going to provide a link in the chat box where you can find the prior UDS reports. It's an aggregate report of all the urban programs. But basically, the uniform data system, in collaboration with the IHS National Patient Information Reporting System, otherwise known as NIPERS, our office created a new data reporting mechanism for the uniform data system to automate data collection, integrate resource and patient management system, otherwise known as RPMS, site data reporting, consolidates RPMS and non-RPMS data reporting, identify non-RPMS sites and commercial off-the-shelf systems, and continue to collaborate with non-RPMS sites to automate data provisioning to the National Data Warehouse. And so basically, in a nutshell, we gather data through the IHS National Data Warehouse. For those urban programs that are on RPMS, we're able to automate those reports. But for those that are using commercial off-the-shelf systems, such as eClinicalWorks or Greenway or any other COTS, as they're called, we work with them first to onboard their system into the NDW so that it's automated, although that can be a long process. So for those that are not able to export their data directly into the IHS National Data Warehouse, we ask them to submit their data, their UDS data on an annual basis, and which is what we're currently in the process to do for the 2019 calendar year data. And then at the end, we aggregate that data and provide a summary report. And again, the the link that I put in there shows, I believe, calendar year 15, 16, 17 and 18. So you can go back and look through there. We're actually, one of our virtual interns right now is looking at those reports and providing us with some trend data and putting that together in a table. So hopefully here in the near future, we'll have some of that information on our website. And again, that's trend data. And hopefully we'll have something like in a nice infographic or something like that. So looking forward to that. Let me see the second bullet point. UDS is an annual calendar year report that provides information about health centers, including aggregate total numbers, age, gender, zip code of residence, insurance sources, race, ethnicity of patients, number of visits by provider type, characteristics of special populations, quality care indicators, health outcomes by diagnosis and services, and disparities. I'm losing my voice here. Next slide, please. Okay, GPRA. So you should all be familiar with GPRA. It's IHS's, they track data measurements for both tribes and urbans. But beginning in fiscal year 2018, IHS clinical GPRA results are calculated from the Integrated Data Collection Systems, otherwise known as IHS, which is a data mart within the NDW, the National Data Warehouse, General Data Mart. Service unit health program data is exported to the NDW by reporting sites for inclusion in GPRA results. The measure logic is programmed centrally within the IHS data mart and mimics the CRS measure logic, which is located here, and there's a link that you all can look at. Each clinical measure has two graphs, and I won't go through the bullet points, but you can look at that by reviewing the link that's provided. And just to let you know, I mean, as far as urbans go, there used to be individual GPRA end of the year reports for urban specific, but beginning in 2018, all UDS GPRA data was included in the national reports with tribes. So if you go in and look for 2019 GPRA report for IHS, which is on our website, you'll see it. It's just a complete report with tribes and urban. So there's not a specific urban report as there has been in years past. Next slide, please. Okay. And Shannon, I think you're up.
Thanks, Rick. So this is one of the two programs, grant programs that we have also in our program. As you all, NCUI, are familiar with, we did award in fiscal year 2019 at the cooperative agreement in the amount of $1,050,000. We are coming to the mid-year as far as the grant cycle. So right now, I believe we're moving into our third grant cycle, which will end in June 14, 2022, and then we would again go through the competitive processes of the applications being submitted. NCUI does, or the cooperative agreement does, provide a number of services in primary focus areas, looking at public policy, research, looking at providing technical assistance and training, education, public relations and marketing, and then also, as I mentioned earlier, is looking closely at third-party reimbursement, but also specifically in line with payment management reform. Next slide. This is also that I mentioned is it is written in statute as far as annual on-site reviews. A lot of our programs do participate in this, and as board members, you probably have sat in as far as having area office staff come to your program and have a meeting with them to talk about conducting the on-site review in general. So one of the main points of the reviews is to ensure that you are meeting contract requirements, in addition to looking overall at your program to ensure that you are providing quality care in addition to ensuring patient safety. So that one of the things about the on-site reviews as well is that it is at this point, I know that there's been discussion of travel. I know that some programs have elected to do them virtually, so that is also an option, and others have elected to do them in person. So that is still really up to the area and how they want to manage that as well. And I think as of today, there's been 2 areas that have elected to do it virtually, and so but a few of them have decided to do it on site as well. So in fiscal year 2021, we are looking to update the on-site review manual, and this has been an ongoing effort. As you read there in fiscal year 2019, we did do a national evaluation of the manual, and we had gone through several revisions as far as making sure that it addressed a lot of the needs that the urban programs have brought to our attention. And what we've realized is that prior versions had stated that, it was redundant. Some of the questions didn't make sense. It felt like, it was just, you were repeating the same words. And so we diligently looked at the pages. We diligently looked at each of the sections. And I went through it, I don't know how many times, maybe 50 times now. And so has Dr. Miyake. So there's been a lot of effort going forth. So one of the new initiatives we have going into fiscal year 2021 is that we are looking again to implement this project and make it available electronically. And so we did start discussions in-house with our what we call the NIPPERS program, who is assisting us with this effort. And so we just had our first meeting last week. And so right now, we do hope that by the end of fiscal year 21 that we do have it implemented. So it would make a lot of the reviews a lot easier as far as making it more seamless and having it available electronically. And so, but there's more to come towards this effort. We are still looking at how we want to implement that. And I guess one of the bigger items that Urban's brought to our attention is that, it's burdensome. It's like having to do this. And so we are keeping that in mind, is that we are trying to make it less burdensome for programs in addition to area staff, but also ensure that we are still following statute and completing these reviews within each year. Next slide.
Thank you, Shannon. And just really quickly, so there's questions in the chat box. The first one is, which 2 areas have moved to virtual reviews?
Which 2 areas? I believe it was the Bemidji area, and the other one was Albuquerque area.
Great, thank you. And then the next question is there any thought to getting site input on updating the manual?
I believe we got site input in fiscal year 19 and 20. We did conduct discussions as far as inputs. So right now, I think we're still finalizing that input as far as having that available. So yeah, more discussion to come as far as how we plan to roll out the electronic version, in addition to having the paper version available as well.
Great, thank you.
So here, looking at partnerships, a number of partnerships, and if any of you have participated on our monthly calls with the programs to provide updates, we usually have these 3 groups on our agenda just to provide urban updates specifically, is the UAL, NCUI, in addition to SCUI, in addition to the Urban Indian Health Institute. And so there's always good content that you all share with programs that they need to be aware of as well, in addition to the IHS updates. Next slide, please. And this is the other other grant program that I mentioned. The cooperative agreement, in addition to this grant, are on the same cycle. So in fiscal year 2019, we did award 33 grantees in the amount of $8.5 million. So they're right now in the application process for resubmission for a non-competitive year, which is due December 1st. But next year will be one of the last years in which we finish this grant cycle. So in fiscal year 2022 is when we take it out again for competitive a competitive application process. So if most of you are not familiar with the 4-in-1 grant program, it has been around since 1976, and so a lot of it is written in statute that this program should exist in urban programs, and those are the 4 areas into which services are provided: health promotion, immunization, in addition to alcohol and substance abuse, and mental health services. Within the last couple of years, we have asked programs to participate in the national evaluation, which still is ongoing at this point. We are moving into year 2. One of the highlights from that first evaluation is that we did implement a reporting template. I know that based on statute, programs were submitting a number of reports, and looking at that and also looking at the requirements, we did create the template to take less burden of programs. And so far, I think most of the programs have looked at it and have been using it and did submit their October reports using it. And so so far, it seems it's been something that's been helpful to programs as far as also managing how they're approaching their activities, and also able to measure the performance within the given template as well. Next slide, and hand it back over to Rick.
Okay, sorry, Shannon. Are we on strategic plan? Okay. So the OUIHP 2017 through 2021 strategic plan guides, supports, and improves access to high-quality, culturally appropriate healthcare services for urban programs. The strategic plan aligns with recently released IHS strategic plan, which is for fiscal year 2019 through 23, to help support healthcare solutions which fit the diverse circumstances of urban Indians and the tribal communities they serve. The OUIHP projects are in line with the OUIHP strategic plans and the IHS strategic plans to improve healthcare services for Indians. And in these slides, there are hyperlinks to these strategic plans. I encourage you to look through them. We're kind of nearing the tail end of our strategic plan, and in the beginning, in 2017, we reported, I believe, monthly to UIOs about our progress. And in looking at the various goals and objectives that were outlined in the strategic plan, we've addressed pretty much all of them. Some of them are ongoing, but certainly we'll have end of the strategic plan summary for everyone to see. And then let me see, the health program strategic plan. There's a link there for that as well. Let's see, next slide, please. Okay, and then this next section just provides a number of available federal resources, but I do want to cover the first one. So next slide, please. Yeah, so the Urban Emergency Fund, this is really important. This is something that we offer at the start of the fiscal year. So the Urban Emergency Fund, or UEF, so folks can make a request to the UEF. An urban or Indian organization must submit a written request to the applicable IHS area director with copies. Oops, did I go ahead? I got ahead of myself, sorry. So it's a discretionary allocation to address one-time non-occurring emergencies and disaster relief efforts taken by UIOs. Each fiscal year, we offer up to $200,000 allocated to the Urban Emergency Fund. Funding is not guaranteed and is definitely subject to the availability of appropriations. And there you can see a definition of an emergency as a sudden, urgent, usually unexpected occurrence or occasion requiring immediate action to avoid imminent or substantial endangerment to public health or safety. and also, just as a caveat, these funds are not intended for administration, maintenance, ongoing operations, construction, or for any other purposes that are not related to emergencies or disaster relief efforts. And if you have any further questions on this, there's Dr. Rose Wiaki's contact information. Certainly you can contact myself or Shannon as well. And there is a hyperlink there for more information on the emergency fund. But here, so the next slide is basically just kind of a, how to go through the process, which is, contacting the area office for sure, the area office director, contracting officer, and the Urban Indian Organizations contracting officer representative. And so you can see there, you're going to want to have a description of the emergency situation, timeline of the emergency, the amount of emergency funds requested, a budget, explanation for rationale, a confirmation that the emergency funds are not within the Urban Indian Organization's existing budget, and a statement on the impact of not receiving the emergency fund. So this very much mirrors the same process for the tribal emergency fund. And so there is definitely a process that goes through this to when it finally becomes approved. But seeing as it's an emergency, we usually fast track that process and either approve or disapprove based on whether or not it's deemed an emergency or not. In the past, let's see, 3-4 years, I believe we've allocated the full 200,000 throughout the year, averaging, I would say, on 3 to 4 different sites who request emergency funds, and sometimes sometimes it's denied because it's not deemed an emergency, or sometimes it's approved but not at the full amount, and then other times it's fully approved. So, but definitely first step is to contact your area and let them know and go through the process that's outlined on this slide. Next slide, please. And again, these are just resources that IHS has in place. And this one's in regards to the repayment program. There's a link there if you have any questions or kind of want to look deeper into this. Next slide. And with the IHS scholarship program, definitely important for your UIO if you have any programs that are geared towards youth or college-age students. Definitely want to let them know about this program in IHS. And again, there's a link there for further information. Hold on, I'm just looking through the chat box. There might have been some questions for the emergency fund. I may have missed this, but what is the time frame to apply? Was that for the emergency fund? I'm not sure, but if it's in regards to the for the emergency fund. So basically, it's as needed, basically, or so. I mean, if whenever the emergency occurs, obviously time is of the essence, so you'll want to go through that process as quickly as possible. And then our turnaround time, it depends, but I would say we try to get a decision out within a week. And then if it is approved, then there's the process of transferring funds to the area office and getting those funds into your contracts. And so I would say on average it takes about a couple weeks, but there's not, as far as a time frame to apply, it's just, if your program or the building gets flooded overnight and funds are needed to help clean up and to restore, then that might be an instance where an emergency funds might be needed. So there's a variety of reasons. It's always just good to reach out to your area office, and they might have some insight as well, but definitely can help you through the process of that. Okay, to go back to the IHS scholarship program, next slide, please. And here's just a list of the different professions that the scholarship programs might be applicable for college students. Next slide, please. More information. Again, I'm not going to go in too deep on this, but lots of information on the hyperlink that's there. Next slide, please. Next slide. Uniformed Services University. This is located here in Bethesda, Maryland. 2 seats for IHS students each year, no tuition. Great program, but again, recommend looking on the link and getting more information and contact information there if you're interested. Next slide, please. And there's the links there to those 2 programs. Next slide, please. IHS job board. So this is where jobs not only here at headquarters but at the area offices can be found. So definitely look at that. I think it's by state. So if you wanted to look at what's available at headquarters, you'd look under Maryland and you know, Alaska or Washington, Oregon, Tennessee, wherever an IHS job might be available, that's where you'll find it. Next slide, please. And that's where you can find the link there. Next slide. Shannon, do you want to talk about this one really quick, the USPH Commission Corps?
Sure. So as Rick mentioned, as far as the presentation is concerned, is there are a number of resources that are available from the agency as far as seeking or healthcare providers to provide services within your healthcare organization. And so as one resource that's available is the United States Public Health Service as far as the Commission Corps. As you read there on the slide, they've been around for a long time, and lately, as far as the service is concerned, there's been a lot of activity as a lot of officers have been deployed to address the COVID-19 effort in multiple capacities, even with the Indian Health Service and the CDC, SAMHSA, and so on. It was all hands on deck for a lot of officers, and still goes as of today. One of the things about, next slide, please. So one of the things about Commission Corps officers is that there are a number of criteria in order to have an officer at your site. As you see on this slide, there are a minimum of 2 years, 2-year commitment to be at your organization. Like Rick mentioned prior, is that a lot of the officers that do graduate were part of the USIS, which is the Uniformed Services University, located in Bethesda. And also this here criteria listed being a citizen. So there is a criteria in order to become a commissioned officer of this service. Next slide. And there is a process in place, and it really does matter in what state you live in. I think as of today, correct me if I'm wrong, Rick, there's probably one area, which is the Bemidji area, that has a Commission Corps on site that's providing services. There used to be 2 in the Albuquerque area, but I think since then that officer did retire. And so it is available. There are steps to take as far as if you're interested in having Commission Corps officer at your location. And this provides just a snapshot on some of those efforts that need to take place in order for that to occur. Next slide. Oh, and we reached the end. And if you do have any questions about any of the content that Rick and I did share, we can take this time to answer those.
And please
Yeah,
feel free. Sorry, just really quickly.
Yeah, I think there's one other Commission Corps person located at the Portland Urban Indian. So I think there's two, if I'm not mistaken.
Okay.
Yep, go ahead.
I just wanted to chime in and let you guys know, please feel free to take yourselves off of mute to ask your questions as well. So if there's any questions you guys have for Commander Beyale or Mr. Mueller, now would be the perfect time, whether it's around AAAHC, the UDS skipper reporting components, any of the extra resources that they had also mentioned, this would be a great time to ask. No questions so far?
I had a question about the AAAHC training. So I know it was mentioned the training will happen in December. And then do we need to make sure we talk to our CEO or whoever that is, our director, to get us registered? Is that the process?
Hi, this is Shannon. Can you hear me?
Yes.
Okay. Yeah, that is just typically how communication is done from our office, is that we do send out to the CEOs all the forms, updates that we have as far as information from the contract. And from there, they'll have a form attached to it to register for the seminar. So then what you would do is just let your CEO know that you're interested in attending, and then you can send those completed forms directly to me for processing.
Okay, thank you. That was helpful.
Thank you.
Any other questions that anybody wants to ask? I'm just looking through the
Looks like Lisa's wanting to ask a question.
No, not at all. I was having technical difficulties, but thank you.
Okay. I saw you shifting. Okay.
I'm sorry, go ahead.
I was just going to say, as folks are maybe thinking about a question, both Shannon and I have been involved with various on-site reviews. Sometimes the area office will ask us to come in and assist, or sometimes it's actually, it can be a case of where we just want to orient ourselves with the program. So we'll come in and do a specific section and be a part of that, which is great, because from the headquarters standpoint, we're typically not involved with those on-site reviews, but gives us a lot of insight, allows us to get to know the program better, the staff, and definitely the board members. So I want to say, for the ones that I've attended, I'm always encouraged when the board members are able to attend, both, the introduction and then also the closeout, when usually during the closeout, the IHS staff will present the findings and definitely go over some of the things that can be improved upon. So definitely important as board members to, if you are able to attend that, to do so, because I think there's a lot of good information that comes from that. I know a lot of times the staff, they spend a lot of time gearing up for the on-site review, and sometimes there's some anxiety around that, but I think at the end of it, at least in my experience, folks are relieved and happy with the process, and feel good about some of the recommendations and things like that are offered. Because typically you have a team that comes in there, which may include the chief medical officer in the area, definitely the area urban coordinator, a fiscal person, somebody from the nursing program at the area office. So, you get a good team that goes in there and does a thorough review, and again, just a lot of good recommendations for improvements that come out of that. And so I've always felt pretty good about each of the closeouts that I've been involved with those on-site reviews. So just want to encourage you all to be involved as much as you can be. I know a lot of you are busy and maybe can only attend the start of it, or maybe just the end of it, or even just to pop your head in and say hi and meet the group. So just wanted to mention that. Thank you.
Thank you, Rick. Did you have a question, Mark?
I just was curious about the areas that have the virtual review, and if there were other areas that were trying to move towards allowing for the virtual reviews other than Bemidji and Albuquerque.
Hi, this is Shannon. So we've asked, we've had that call on an, we've had a number of area urban coordinators ask us that question. And so we did recommend that they reach out to those area urban coordinators who have conducted to gain information insight into how they did it. And so that's been the route we've been using. And I believe that right now we haven't received an update since we haven't had a call with them. But so far we haven't received any questions regarding how to conduct the on-site reviews.
Thank you.
Are there any other pending questions now that we've had some additional commentary?
I just wanted to add a comment, not really a question. That's okay?
Sure. Yes.
I just wanted to add to what Rick said. I find that it's been extremely helpful to have our board members meet the reviewers and have the opportunity to actually ask questions directly, because they may not have thought of it beforehand, but while the briefing was going on, a question pops up and they're able to get a direct response from the team that's doing our audit. And so it's always nice to have that active engagement and participation, be able to clear up if there's any misunderstandings or confusion, or really just expand their depth of knowledge. So I appreciate, Rick, that you added that to the conversation, because I do think that active participation from the boards for all the audits actually is always really helpful. So thank you for that.
Thank you for those comments, Sonia. Any other questions before we break for the day? I think we can go to the next slide, please. Okay, so the next and final session that we have in our Creating Resilient Board of Directors members in the era of COVID-19 series, we will close out with the final session, which is going to review the Board of Directors self-evaluation tools. The objectives of that is just to review Board of Directors self-evaluation approaches and review sample tools and a UIO case study. So the presenters will be Mr. Tony Scucci, which is a consultant from BoardSource. Many of you guys may know him as well. And also Luis Cervantes of the United American Indian Involvement Incorporated UIO in Los Angeles, California. So they'll both be jointly presenting the Board of Directors self-evaluation tools. And that will occur on November 9th at 1 p.m. Eastern time. So with that, I think we can go ahead and move to the next slide and adjourn. Again, thank you guys all so much for your participation. We look forward to seeing you on November 9th. And if you have any further questions, please feel free to reach out to Mark Clark, and that's mclark@ncui.org. Thank you all. Have a great day. Bye-bye.
Great. Thank you.
Bye.
Bye.
Great job.
Thank you.
Goodbye, everyone.